Falls are the most common accidents in nursing centers. The risk of falling increases with age, and a history of falls also increases the risk of falling again. Falls is often a sign of other health problems. Maybe they're developing a urinary tract infection and they're a little dehydrated. That can make them dizzy and cause a fall. Maybe they've developed a blood clot in their leg and it hurts to stand up and they fall. So a lot of times it could signal another health problem, especially in the elderly and those that aren't able to tell you what's wrong. People older than 65 are at a greater risk. Most falls occur in resident rooms and bathrooms. They're most likely to occur between 4 and 8 p.m. They're starting to get tired. Usually they've already had dinner by then. And also, a lot of times there's less staff on the floor to be able to monitor folks. It also happens during shift changes. Everybody's at the nurse's station trying to get their assignments, and there aren't as many eyes out and about because a lot of times you can see things that can indicate the person is about to take a fall, and you can catch them and help them before it happens. Poor lighting, cluttered floors, incorrect bed height, and out-of-place furniture can also be causes. So are wet and slippery floors, bathtubs, showers. Wheelchairs can cause falls if they don't fit the person or if they're in poor repair. Needing to use the bathroom, especially to urinate, is a major cause of falls. They have to go, they don't want to have an accident, they try to take themselves because there's no one to help them. By the time they stand up, they pee on the floor, and now the floor's wet. So they need to go to the bathroom. That's why it's very important that you answer those call lights so quickly to help them before they try to do for themselves what they're typically not able to do. Nursing centers have fall prevention programs. Common sense and simple safety measures can prevent many falls. The goal is to prevent falls without decreasing the person's quality of life. The entire health team must protect the person from harm. If you see something unsafe, tell the nurse at once. Do not just assume that the nurse knows or that someone is tending to the matter. If you see a spill on the floor, clean it up. Put a wet sign on it. Call housekeeping. Do something. Don't just leave it there unattended. The care plan will also list measures for the person's specific risk factors. I worked in one facility where this lady loved to walk around in her socks. Socks are slippery on tile floors. So the family argued with us. She wants to wear her socks, just let her wear her socks. She's going to fall. And finally she did. And when she did, she had to get 12 stitches in her head. So when she came back, we told her, you can wear socks as long as they have treads on the bottom. And that worked. She was happy in her socks, and we were able to keep her safe. So some measures can be done to help the person be happy and help the staff be happy as well. Bed rails. The bed rail is a device that serves as a guard or barrier along the side of the bed. They're raised and lowered. They lock in place with levers, latches, or buttons. They can be half, 3/4, or the full length of the bed. If they need their bed rails, keep them up at all times except when you're giving bedside care, and that's only on the side you're working. Bed rails do present hazards. Entrapment is a risk. They're considered restraints by OBRA and the Centers for Medicaid and Medicare Services if the person who is able to get out of bed will not be able to, or if they can't lower them without help. Accrediting agency standards and state laws affect bed rail use.
When providing bedside care now, with the beds that don't have the rails anymore, is it a two-person job now, or how do they go about that?
It is, yeah. If the bed is elevated to provide care, and most of the time it will be,
yeah,
then you need another person on the other side of the bed, because if the bed is raised, that makes it even a greater risk for them to get hurt if they should fall. Bed rails cannot be used unless needed to treat a person's medical symptoms. Maybe they have a seizure disorder. They might have tremors with Parkinson's or cystic fibrosis or multiple sclerosis. The need for bed rails is carefully noted in the medical record and the care plan. They're allowed when the person's condition requires them. And again, they must have a doctor's order. One doctor made a special order for a lady who liked her bed rails because she was blind. She said the rails made her feel safe because she could feel the sides of the bed rails. If they use the bed rails, check them often, report to the nurse that you checked on them, and if you're allowed to chart, record when you checked the person and what were your observations. But if they use rails, since it's considered a restraint, you will have a form that you have to document every 15 minutes and every 2 hours. Next, handrails, grab bars, wheel locks. Handrails are in hallways and stairways of all nursing homes and hospitals to allow patients to have a little stability while they walk. Grab bars are in bathrooms and shower and tub rooms so they can hold on to the bar as they sit or stand. Bed legs have wheels. The wheels have locks to prevent the bed from moving. They should be locked at all times except when moving the bed. Make sure the wheels are locked when you provide bedside care and where you transfer a person from the bed to the chair or vice versa. Wheelchair and stretcher wheels are locked during transfers. The transfer or gait belt, a device used to support a person who's unsteady or disabled. It goes around their waist, usually right above their navel, and you want it to be snug but not too tight. You have to be able to get your fingers underneath to be able to support the person. The belt is used to prevent falls and other injuries. Grasp under the belt to support the person during transfers or when you're helping them walk. There's a picture of a belt on page 155, figure 11-9. The falling person. Falling may be caused by weakness, lightheadedness, or dizziness. It could be caused by fainting, slipping or sliding on spills, waxed floors, throw rugs, or improper shoes. So the gait belt goes around the person's waist. And you would make it snug enough that you could get your fingers underneath, and you put your fingers underhanded on each side when you help the person to stand and when you help them to sit down. And when you walk with them, one hand is in the back, one hand is on the side, and their arm hangs between your arms. This particular belt latches with a clip. The ones we teach in the classroom actually have teeth on the buckle. But you can use either or. And wherever you work, your facility will provide those for you, and they will train you on how to use them. Yeah, don't try to prevent the fall. So if you're walking with a person and they start to fall, gently ease them to the floor. If you try to hang on to them and keep them up, they're most likely going to take you down with them. So the best thing to do is just gently lean their body into yours and go down to the floor with them. And that helps them keep from getting hurt from the fall or from whatever caused them to fall. Once they're on the floor, do not let them get up or move until the nurse checks them for injuries, because even an assisted fall can cause a fracture. It could be a hairline fracture. The nurse needs to check them out before they try to get up. And it might have been for something else, and they may not want them to get up, and they'll end up sending them out to the hospital. Maybe they threw a clot, or maybe they fell because they're so dehydrated.
What's the first step if you do whenever you find somebody who's fallen?
Yell for the nurse. So the first thing you do is get the nurse there so the nurse can check them out. If they're bleeding, you may apply direct pressure. Just know your center's policy. One facility where I go, if anybody falls and it's not witnessed, they do neuro checks on them to make sure they did not hit their head, because no one saw it. And they don't even take the patient's word for it, because a lot of them don't know. They'll go back every 15 minutes and check their hand grips, their pupil response, and their level of orientation. After a fall, the incident report is completed. A confused person may not understand why you don't want them to get up. You might need to let them move for their own safety. Don't ever use force to hold them down. Stay calm and call for help. So if they insist on getting up, they're fighting with you, then you can't fight. So just try to get the nurse there as quickly as possible. Residents have a right to feel safe. The fear of falling does not make a person feel safe. A fall can seriously affect a person's quality of life. Some people may feel restricted by the use of safety devices. Before you move someone, always explain what you're going to do and what they need to do. Also give step-by-step instructions as you progress. Do not move the person without telling them first. Even if you think they're not going to understand, you think about what would you do if someone walked up and put their hands on you. Always tell them before you touch them. Do not let the person talk you out of performing safety measures or using a safety device. Safety is always a priority. I went into a room one day, a nursing assistant was helping a patient out of her bed, and she was moving her by herself. The care plan called for Hoyer lift, which means she should have been in a lift. As soon as the staff member raised the patient onto her feet, the patient fell forward. They both went into the floor. The staff member ended up with a cracked elbow, and the patient ended up with a broken nose. So always, always, always follow your care plan. And the nursing assistant had to go before the board because she did not follow the care plan. I don't know if she lost her state registration or not, but she probably did. Help prevent falls, but you cannot interfere with a person's rights to do so.